Hi, I'd like to welcome everyone to today's webinar, the CAPE webinar, The Devil is in the Ddimer. My name's Sam Campbell. I'm a professor of emergency medicine from the QE2 in Halifax. We'd like to just take this opportunity on this evening to wish our Jewish colleagues an easy and meaningful fast over Yom Kippur, which is obviously a very important time for them. Today's webinar topic was independently conceived by our scientific planning committee, which consists of Doctors Eddie Lang, Stacey Kitts, Rob Stenstrom, and Kira Grewell. The program received financial support from BMS Pfizer in the form of an education grant. And all efforts were made to mitigate any potential biases, as you can see. Just a little bit of background on today's webinar development. I'm sure that most of you would not be able to remember a shift where you didn't at least consider DVT or PE in a patient. It's been said in the current healthcare dysfunction that we face that complexity is the new acuity and multimorbidity is becoming more the rule than exception. So many of the sick patients that we see seem to be at the risk of VTE, either as a primary problem or as a comorbidity. And recurrent cognitive challenges appear with older patients, pregnant patients, those already taking anticoagulants, those with suspected recurrences. These are not diagnoses that we like to miss. They can be devastating, and at the same time, the treatment is not benign. So overdiagnosis presents a significant threat to our patients. If you're feeling that you're alone in your confusion as far as this topic's concerned, in a needs assessment survey, 100% of respondents agreed that knowledge and comfort in managing VT in the setting of chronic kidney disease or suspected recurrent VT in patients on and off coagulation was a somewhat or very important skill set for emergency physicians. Yet on a scale of 1 to 100, the average self-assessment rating was only 58. So it's clearly an important topic, and it's clearly one that makes us nervous. Our learning objectives are as follows. And I'd also say to increase the interactivity of the session, we encourage you to use the chat feature to submit your questions, and we'll try to address as many of those as we can. We'll also be doing some audience polling throughout the webinar, and for that you'll need to have access to the polling feature, which you'll see now, which you can access by the website on this QR code. If you want to cut and paste it, it will also be put in the chat box. Without further ado, we have fantastic and very well-informed speakers, and I'd like to introduce them. Firstly, Kirsten DeWitt is an associate professor in the Department of Emergency Medicine at Queen's, an associate professor in the Department of Medicines and the Department of Health Research Methods, Evidence and Impact at McMaster. She trained in internal medicine, emergency medicine and research in the UK, and then completed a thrombosis fellowship in Ottawa in 2013. Since then, she's worked in both emergency medicine and thrombosis. Dr. DeWitt leads a research program at Queen's that focuses on the diagnosis of bleeding and clotting disorders in the emergency department and is funded by CIHR and PSI. Dr. Lani Castellucci, the second speaker, is an assistant professor in the Faculty of Medicine at the University of Ottawa. She's a scientist at the Ottawa Hospital Research Institute and a thrombosis specialist, with clinical and research interests focused on prevention, diagnosis, and management of anticoagulant-related venous bleeding and venous and arterial thromboembolism. She's also a member of the ISTH World Thrombosis Day Steering Committee, and she sits on the board of directors of Thrombosis Canada, a national organization promoting patient education and improved outcomes in patients with venous thrombosis. And an unsolicited plug that this is an incredibly useful website for just-in-time information, the Thrombosis Canada, if you have questions about this topic during a busy shift. Dr. Castellucci is also an active member of the Canadian Venous Thromboembolism Clinical Trials and Outcomes Research Network, She's a recipient of the University of Ottawa's Tier 2 Research Chair in Thrombosis and Anticoagulation Safety and the Heart and Stroke Foundation of Canada's National New Investigator Award. So we'll start with Dr. DeWitt. And if you bear with us for a couple of seconds while we switch the speakers.
Hello, it's a pleasure to speak to you tonight about diagnosis of pulmonary embolism. As you've heard, we have some polling questions that are coming up. So if you have a chance, feel free to bring up Poll Everywhere on a browser or on your phone in preparation for some questions that are coming up. I'm Kirsten DeWitt. So my conflicts of interest include an honoraria for this session and also an unrestricted grant from Bayer back in 2016. Bayer are the manufacturers of rivaroxaban. So many people ask the question, why would I want to test for pulmonary embolism without ordering a CT scan? And there are many advantages to doing that. Those advantages are not just that the prevalence of pulmonary embolism amongst everyone we test is very, very low. It's about 5%. So only about 1 in 20 patients we test for pulmonary embolism in the emergency department have PE. It's not only that if we order a CT scan, then we're going to expose all of our patients to radiation, but there are other things which I'm sure we're all aware of, like if you order a CT scan in the emergency department, the patient's going to stay in the emergency department for longer and block beds. We have finite resources for CT in pretty much every hospital in Canada. So there's a chance that you could be blocking the CT to an inpatient who may actually have a septic abdomen or some really serious complication that requires a surgery based on their CT scan. But the thing I'm going to mention here that people don't talk about is that as many as 1 in 20 positive CT-PE scans are actually a false positive. So CT does not always identify pulmonary embolism correctly. And in fact, the radiologists are looking at a filling defect on the CT scan rather than seeing a pulmonary embolism. And if 1 in 20 of our positive CT scans are false positive, then that's concerning, not only because the patient has to start anticoagulation unnecessarily, but also because of the hidden side effect of being diagnosed with pulmonary embolism. PTSD, anxiety and depression, and this over-reliance that many patients have on anticoagulation, whereby they really don't want to stop their anticoagulation. I've done many different studies looking at testing and diagnosis of pulmonary embolism, and one of those studies we asked patients about psychological distress that they'd experienced after being diagnosed with pulmonary embolism. My presentation has a variety of quotes, and I've recorded different people saying these quotes, and you may actually recognize some of the voices, but none of the people who I recorded saying these quotes were actually the people who were interviewed.
When the doctor said it was a blood clot and it could go any minute, I could have a stroke, I could have a heart attack, that was a whole other ball game. That has got to be one of the most traumatic things in my life.
And this is something we just don't talk about because we don't see it in the emergency department. But in my thrombosis clinic, I have lots of patients who are very well educated, who don't understand even the basics about pulmonary embolism. And it's very common for patients to think they're at risk of stroke and heart attack. And it's very common for patients to believe they're at risk of death after they've been told that they have pulmonary embolism. So by implementing another approach to testing for pulmonary embolism, we can reduce the number of CT scans, and that would translate into a reduced number of false positive CT scans. So what approach should we take? Well, I think we all know about it. We have to study for this in our exams. The first step is to calculate clinical probability. And by far and away, the most researched, most validated, structured pretest probability estimate is the Wells rule. And this is a screenshot from MD Calc. So we would calculate the Wells rule. And the reason we're doing that is we need to find out if the patient scores 4 points or less. When you look at all the patients who are tested for pulmonary embolism, 85% of the patients we test in Canadian emergency departments fall into a well score of 4 points or less. So the vast majority. And if the patient scores 4 points or less on the well score, then the first option to rule out pulmonary embolism without ordering a CT scan is to order a D-dimer and interpret it using the standard cutoff. There is absolutely nothing wrong with doing that. I know we're a little obsessed with adjusting our D-dimers, but there is no problem with using the standard cutoff, which is almost always 500. Although there is one assay in existence based on the IL test, which has a different lower cutoff. So know your hospital's recommended cutoff, and you can stick to that. If the D-dimer is less than 500 or your hospital cutoff, then you can exclude pulmonary embolism without CT scan. This is probably the most validated rule-out test really in existence to man. So this has been validated in most countries of the world on tens of thousands of patients. If you want to try adjusting your D-dimer, then you could adjust the D-dimer, but again, the patient has to score 4 points or less on the well score. And ideally, you would have documented that. And of course, age adjusting D-dimer would mean that you'd multiply the age times 10 in a patient who's more than 50 years of age in order to create a new cutoff between positive and negative. There's one more option, and that last option would be to use a single cutoff in patients who score 4 points or less on the well score of 1,000. And that would be based on the PEGG trial, which was clinical probability adjusted D-dimer, which showed it was safe to actually just use the standard cutoff of 1,000 if the patient scores 4 points or less on the well score. So the well score is kind of tough to remember, and most people have to bring out MD Calc or some other aid to calculate it. The years score was derived to try and address that problem. So the researchers for the years score took the well score items and they boiled them down to the absolute minimum number of items that they needed to create a score. And from that, they found that they could use clinical signs of deep vein thrombosis, hemoptysis, and pulmonary embolism most likely. And to use the years score, then everybody has a D-dimer. It doesn't matter what your years score is, you order a D-dimer. And if the D-dimer is less than 500, you stop right there. If the patient has no years items, then you can actually increase the D-dimer cutoff to 1,000. But if they have 1, 2, or 3 of the years items, then you would use the 500 cutoff. And again, that would be for the standard assays that the manufacturer recommended guidelines would say to use the 500 cutoff. So it's a little confusing because we have 2 kinds of clinical probability scores, and we have 3 ways to adjust our D-dimers. So we have age adjusted, clinical probability adjusted, and years. And if you took the same patient, you could run them through these different tests, and one time the patient might get a CT scan and another time they might not, which I think breeds a little bit of confusion. So let's go a little bit into the comparison between adjusting D-dimers. The only prospective studies that exist for D-dimer adjustment for pulmonary embolism and deep vein thrombosis are the validation studies. So here I have the PEGG study, which was the clinical probability adjusted D-dimer study for pulmonary embolism performed in Canada. The 4D study, which was clinical probability adjusted D-dimer for deep vein thrombosis, again here in Canada. The years validation done in the Netherlands, and the Adjust PE in France and Switzerland. And the first thing you see is the prevalence of pulmonary embolism is considerably different across each study. So in Canada, 7.5% of patients were positive for PE. In the Netherlands, with the years, 13%. And in France and Switzerland, for Adjust PE, 19% were positive for pulmonary embolism. So we've already done this meta-analysis, which was published earlier this year. And what we did was we pulled all the diagnostic studies for the standardized testing for pulmonary embolism, and we categorized them by country where the study was performed. And you can see what we've tried to show are the prevalence of pulmonary embolism amongst the North American cohorts compared to the European cohorts. And you can see in that top red circle that the North American cohort has a much lower prevalence of pulmonary embolism, definitely lower than 10% and closer to 5%. And in Europe, they have a much higher prevalence of pulmonary embolism amongst those who are tested in the emergency department, somewhere between 10% and 30%. And then it's even more fascinating because if you look, all of these patients were tested in exactly the same way. They were tested using either the Wells score or the Geneva score and Ddimer with a standard cutoff. So the same patients would have gone on to have CT scanning in between the studies, no matter if they were in Canada or if they were in Europe. And actually, when you compare the positive yield of the CT scans, so the proportion of all CTs that were positive, we find that in Canada and the States, there's actually a much lower proportion of positive CT scans, even when you apply the same diagnostic tests as they would do in Europe. So that's telling me that the people we test here in Canada are different from the patients in Europe. And there are probably patients we test here in Canada that they wouldn't test in Europe, and probably vice versa. There are probably patients tested in Europe that we are not testing. So going back to the comparison, if you look at how effective these rules are at avoiding the use of diagnostic imaging or CT scan, you can see that clinical probability adjusted D-dimer for pulmonary embolism with a PEG study, only a third of patients need CT scanning. So there's a huge bang for your buck in Canada. 2/3 of patients don't need a CT scan. Compared to the years algorithm, half of them needed a CT. And in Europe, the adjust PE or the age-adjusted D-dimer study, 65% needed a CT scan. And then you say, well, that's fine, but are they safe? And what's the false negative rate? And it's important to understand they have this weird thing that has developed in pulmonary embolism studies, whereby all of these studies report the incidence of either deep vein thrombosis or pulmonary embolism over the next 90 days. So this is an assumption that a patient's diagnosed with pulmonary embolism or deep vein thrombosis, maybe at like day 89, we assume that we missed that diagnosis 89 days ago. And so this is really, truly a worst case scenario. And you can see the false negative rates are really low. They're well below 1% and often very, very close to zero. But then you say, you know, the false negative rate, that includes everybody, even people who would normally have had pulmonary embolism ruled out with a usual cutoff of 500 D-dimer. So here, what I've done is I've pulled out the number of patients who actually had a different testing because their D-dimer fell in between the new cutoff. So for example, with the PEG study, there were 315 who were low probability, and there was a D-dimer between 500 and 1,000. And you can see for each of these studies, the number of patients included that actually had different management based on the thing that was different about this study varies. But the number of patients who subsequently are diagnosed as VTE in the next 90 days is still very low. And I also pulled out for all the studies that I've published the name of the D-dimer test for the false negative D-dimers, and you can see there's a huge variety. So it doesn't seem that there's one D-dimer assay that's better than another. For the years study, for example, there were 1,300 patients who had no years items, and they had a D-dimer less than 1,000. And of those patients, only 4 were diagnosed with VTE in the following 90 days, all with a D-dimer between 560 and 900. And there were 3 who did have years items who had a D-dimer less than 500 who were subsequently diagnosed with VTE. So you say, what's the issue? You know, a lot of people feel that they're following the evidence and they feel comfortable. Well, we interviewed a lot of physicians in Canada, emergency physicians, to find out how they were testing for pulmonary embolism. And we got a lot of information. So I'm just going to read you a few quotes.
Taking the time to sort of look up the tool and what have you, because obviously can't remember everything. What point value goes with what item and what have you. So like sitting down and looking at it or looking it up or what have you, it might only take a minute, but it's a minute where you could have been seeing the next patient or finishing up your charting or whatever.
You know, your grandmother didn't look at a recipe card to make your favorite dishes by memory, right? She gave it to you and you wrote it down. You do it a few times and you do it often enough, you stop looking at the recipe card. You'd also tinker with the recipe card to add a little butter or mint or something. You tinker with it a little bit to make it suit you better.
We find that a lot of people or physicians working in the emergency department don't like to use the Welsh score for many, many different reasons, but they find it challenging. And I think for us to, particularly to adjust our Ddimer, it's so important that we first document and assess the patient with the Welsh score and document that they have 4 points or less. So we also heard in this study that actually a lot of people used gestalt instead of the Welsh score. And I hear a lot of the time, it's okay, I can use my gestalt instead. And actually, out of all the cases that we assessed with different emergency physicians in Canada, more than half of the cases were assessed using gestalt on its own, and about 11% of cases patients used the PERC rule, or the physicians used the PERC rule followed by gestalt. And the issue that I noticed when I was reviewing all of these interviews was that gestalt really was synonymous with I'm going to order a CT scan. So almost every time that gestalt was used, the physician assessed that the patient was high risk for having pulmonary embolism and needed a CT scan. If you compare that to the Welsh score, we know that only 5% of patients are high risk, 10% are moderate, and 85% of patients fall into the low risk category. So again, more examples of what we heard.
Because you already know the patient's getting a CT. You don't need a decision rule for that.
But I think that in this patient, because I am so concerned about PE, that I don't think I would apply any of the rules as mentioned. I can apply the PERC. I can probably apply the Wells criteria. But to be honest, I'm so concerned that I would move straight ahead to the CT.
So my advice would be not to use gestalt, because gestalt always seems to rate a patient as high risk. Or essentially it's a bypass to using Ddimer. The other thing that we heard a lot of was, you know, the Welsh score is fine, but it's actually not for me. It's not for emergency physicians. It's really for residents or for medical students. So it's for teaching about how to test for pulmonary embolism. But actually it's completely the opposite. The Welsh score is absolutely 100% for us. It's an evidence-based tool to test for pulmonary embolism. And then last of all, we heard, you know, the Welsh score is fine, but, you know, it doesn't apply to my patient.
The answer is actually he is excluded. He is overtly excluded. He's had a previous PE, which is a point, but he has a known disease like his factor V Leiden. He is just out, like he is completely out of all of those derivation studies. He is not even included. I don't even know whether the original derivation studies, because his first one when he was 13 or something like that, I don't even know whether those studies included kids that young. They probably did. They probably excluded them.
Just an example of one physician who felt they didn't want to use the Welsh score in Ddimer because the patient had factor V Leiden. And honestly, there is no exclusion to using the Welsh score in Ddimer. A possible exception might be in pregnancy, but there is no other patient that we can't use these scores for. So I'm going to have a walk through a case, and then we're going to have a pause for a break, and we'll hand over to Dr. Castellucci. If you can, again, please feel free to get Pull Everywhere up. So this first case is a 74-year-old lady, and she has lung cancer, and she's being treated with crizotinib. She's presented to the emergency department with breathlessness, palpitations, and she felt dizzy when she was walking up the stairs. So I would like for you to look up Pull Everywhere and log into the CAPE account. And again, I think we have in the chat, you can copy and paste in the into your browser. So for this lady, 74-year-old lady who's got lung cancer, and she's got symptoms certainly suggested of possible pulmonary embolism, what would be your next step to test her for pulmonary embolism? So A, would you order a CT pulmonary angiogram? Would you order a D-dimer first? Would you calculate the Wells score for pulmonary embolism? Would you work out your gestalt estimate for the probability the patient has pulmonary embolism? Or do you think that both B and C could be correct? So take your time to answer on Poll Everywhere, and we're going to advance to see, I think it does take a few minutes for some responses to come through. So it's nice, we're getting a nice variety of answers. I'm quite happy to see that nobody is going to do a gestalt estimate. So right now we're evenly split between calculate the Wells score and either calculate the Wells score or D-dimer. Okay, I'm going to move on to look at the correct answer. So probably the correct answer might be B or C, although neither would be wrong. So the reason why I say ordering a D-dimer would be reasonable is if you chose to use the years criteria. So if you're using years, then you're going to order the D-dimer regardless for every patient. And otherwise, if you want to use the Wells score, then you would use the Wells score first to determine if it's safe to take a D-dimer or adjust your D-dimer. I'll be happy to answer some questions towards the end. I'm sure there are plenty of questions. So the next question, can you age adjust the D-dimer for this patient? A would be no, you can't age adjust. B is yes, you can. C depends on the Wells score result. And D, D-dimer can't be used at all in this patient who's got cancer. So again, it'll take a few minutes for the results to come through. Okay, so most people think, yes, we can age adjust, or it depends on the Wells score. I'll give just a second longer. So the correct answer would be it depends on the Wells score, because we have to have a Wells score of 4 points or less. And actually, it's quite possible in a patient with cancer to have a Wells score of 4 points or less, because cancer, you might remember, only allocates 1 point for the Wells score. It would depend on the presence of other items in the Wells score as to whether it would be safe to age adjust. So we also did a study interviewing patients actually across the world, most of whom were emergency physicians, some were hematologists or oncologists. We asked them about how they tested for pulmonary embolism, specifically for cancer patients. And this was the resounding response.
What I would not do with somebody in this situation is get a D-dimer, not for someone with an active cancer.
If I think it is a PE or a DVT and they've got cancer, then you just scan them.
Oh, sorry, I've missed one. Oh, I'm not doing very well here with my slides. Let's try one more time. Yep, I think someone's, we'll move on to the next one.
Well, yeah, I think I pretty much always do, because my only other alternative would be to do a Ddimer, and I don't trust a Ddimer in cancer patients. If it comes back negative, I'm not necessarily convinced that it's not a false negative. And if it comes back positive, I'm no further ahead than when I started, and I had the patient wait even longer.
So all of these physicians that we interviewed seemed to think that Ddimer was not a trustworthy test for patients with cancer. And they also seemed to think that it was likely that our patient would fall into the high probability for pulmonary embolism. So we did a whole research program looking at how good is Ddimer in cancer patients. So just as a reminder, we would look for a well score of 4 points or less, or we would use the year's items. So this was the result of a systematic review and meta-analysis that we did earlier this year. And we looked at both pulmonary embolism and deep vein thrombosis. And we looked at Ddimer as a standalone test, so not even in combination with clinical probability estimate. And you can see that the sensitivity for pulmonary embolism was extremely high, approaching 100% when it was used as a standalone test. The same for deep vein thrombosis. The specificity for pulmonary embolism was much lower, somewhere in the region of 14%, and the specificity for deep vein thrombosis was about approaching 50%. So what this tells me is that pulmonary embolism is a good way to pick up, Ddimer is a good way to pick up pulmonary embolism in people with cancer, but it probably isn't very efficient. So we looked at other studies that report the safety and the efficiency of ruling out pulmonary embolism and deep vein thrombosis using the combination of clinical probability and Ddimer. And this was only using a standard cutoff for Ddimer, so there were no studies evaluating age-adjusted Ddimer or any other kinds of adjustments. And you can see here that about 1 in 10 patients could have pulmonary embolism or deep vein thrombosis excluded on the basis of the clinical probability in combination with a negative Ddimer. So although it wasn't highly efficient, the yield would be about 1 in 10 amongst all those patients that you would apply the well score and Ddimer. So I'd be happy to take any questions. I believe we're going to be handing over to Dr. Castellucci, and I can answer some questions in the interim. Otherwise, we will answer questions at the end.
So Kristen, if you don't mind, I'll give you a couple while we're switching over to Lana's slides. The first is a combination. Can we still use the perk in people who recently had a COVID vaccine? And what about people in whom you're ruling out COVID infection, but you're worried about PE?
Yeah, okay, so 2 things that it can be difficult to tell the difference, COVID and pulmonary embolism. To address the first question, I think the first question perhaps is a reference to VIT, vaccine-induced thrombocytopenia thrombosis. And absolutely, you can use the PERC score for any patient who is unlikely to have pulmonary embolism. And an easy way to operationalize that would be to do the well score. And if they score 4 points or less, if you wanted to, you could just use the PERC score then. And it wouldn't matter if they just had a vaccination or not. The only time I would consider the possibility of VIT and therefore a possible thrombosis because of the specific relationship with a vaccination to COVID would be if the patient had a low platelet count, unusually weirdly low platelet count. So patients can't have VIT if they have a normal platelet count. So I would treat the patient exactly the same way. And if they've had a vaccine, I just cast my eyes at the platelet count. For the second question, absolutely. Anyone who might have COVID, you can 100% treat or investigate for pulmonary embolism the same way as you would anybody else. And in fact, COVID does go hand in hand with pulmonary embolism in the same way as cancer does. And it makes sense that even age adjusting or clinical probability adjusting might be even more appropriate in those patients. So I would use the same approach. I wouldn't change my testing strategy.
Let's just sneak in one more. What would your recommendation for people with a Wells score of 4.5 to 6, but whom are older than 50 years of age? Is it okay to change the cutoff on the basis of age?
It's a great question. So with the PEG study, the clinical probability adjusted D-dimer study, which we did here in Canada, that was part of the protocol that if you scored a moderate probability, so 4.5 to 6 points, then we introduced ruling out pulmonary embolism with a D-dimer at the standard cutoff of 500. But what I would say is that it was a very small patient group, and there were only 40 patients in that study who had a moderate probability and a D-dimer less than 500. And those are literally the only patients that have been studied prospectively. So I feel that is not nearly as well validated as using the 1000 cutoff in patients with a low probability. And I would certainly not age adjust the D-dimer in patients who have a higher Wells score than 4 points. It's not been validated to do so. And I think as soon as you start edging up the threshold for D-dimer, then we have to be more conservative.
Fantastic. Thank you so much. We have more questions, but I'm going to we're going to switch across to Lana, and then we'll answer the two of you questions together at the end.
Hi, everybody. I'm Lena Castellucci. Thank you for having me this evening. So I'm going to continue on, and first you'll see what my disclosures are relevant for this evening's presentation. And I'm going to continue on from where Kirsten left off in terms of cases to discuss. I'm just waiting for our slides to transition. So these are my conflicts of interest for this evening. I have received honoraria for speaking engagements for different pharmaceutical companies that are listed here. And I'm going to continue with Kirsten's patient that she introduced in the first case. So you'll recall Angela, who's a 74-year-old woman. And instead of her having a malignancy, what I've given her for her history is atrial fibrillation. And importantly, she has the same symptoms that she presented with in Kirsten's case. She's had palpitations, shortness of breath, and some dizziness with exertion, in particular when she's walking upstairs. And when you see her in the emergency department and gather some more information, in addition to atrial fibrillation, she has hypertension and some chronic kidney disease with a baseline creatinine of about 150, giving her creatinine clearance less than 50 mils per minute. And that's important because of the dosing that she's on for her anticoagulation. She takes reduced dose rivaroxaban, 15 milligrams once a day, and that's an appropriate dose adjustment for her creatinine clearance. And her only other medication is perindopril for hypertension management. In seeing her in the emergency department on your assessment, her vitals are listed here. So she is tachycardic, and you will have noticed from her medications that she's not on any rate controlling agents because she hadn't previously needed anything. She's mildly hypertensive, and she is hypoxic on room air with stats of 92%. And your physical exam I've listed here. So her chest is clear to auscultation. Cardiac exam is relatively benign. She's not volume overloaded. There's no leg edema. She doesn't have elevated JVP. And some of the labs have already come back for you because they were drawn when she was initially put in her room, and she's not anemic, which is certainly helpful in patients who are on anticoagulation. You want to make sure that they're not bleeding. So her CVC is normal. Her creatinine is slightly higher than her baseline. And she does have a mildly elevated troponin, but her ECG shows atrial fibrillation that is tachycardic at the 115, no ST changes or anything concerning for ischemia. And she's also had a chest x-ray, and in consistency with your physical exam, it doesn't show anything concerning for infection or volume overload. And so now we need to consider what is happening in this patient. So her cardiac workup is largely negative. She does have a slight troponin elevation, but she's already on anticoagulation. And when you're going through what you're considering for this patient as cause of her symptoms, you do think about pulmonary embolism. She is on an anticoagulant. Is it possible to get pulmonary embolism in patients who are already anticoagulated? And I think we've all seen cases where we do get breakthrough thrombosis despite being on anticoagulation. And so again, I'm going to ask what's next, and do we need to pursue imaging as part of her workup for pulmonary embolism? And so again, we're going to use PUL everywhere, and I've included the same options as in the first case with Dr. DeWitt. And so we'll go to the next slide where you guys can vote, and you're going to tell me pretty evenly, it looks like, that you think both B and C are correct. So wanting to determine what her pretest probability is with the Wells score, or order a D-dimer. And again, based on what we learned from Dr. DeWitt earlier, I would agree with you that we're going to want to determine pretest probability using the Wells model, and the D-dimer is helpful both for the Wells model as well as for using the years algorithm if that's what you choose to use. So we do determine what her Wells score is, and on the objective criteria of the Wells score, she gets 1.5 points for tachycardia. The other thing that you could consider giving her points for is no alternative diagnosis, more likely than pulmonary embolism. And so if you thought PE was the most likely diagnosis, you could add 3 points. I'm going to leave this as though she's low pretest probability with a score of 1.5 points. And so it forces us to order a D-dimer. And we do that, and it does come back elevated at 1200. And again, I've specifically chosen 1200 in this patient because, as we heard from Dr. DeWitt, we want to either use our standard cutoff of 500 for most of the assays that are available, or we could consider age adjusted. And for this patient, it would be 740. So when we have an elevated D-dimer, we do need to consider diagnosis of pulmonary embolism using imaging. A CT scan is done in your emergency department. And in our patient, it does actually come back positive for PE in the left distal pulmonary artery extending into the lobar arteries. And so this is something that, as I mentioned, we do see, but it's not very common that we see breakthrough thrombosis in patients who are on anticoagulation. And so now we need to consider what's happening with our patient and what's going to be our next step for management. When we're considering whether or not this is really breakthrough thrombosis and an anticoagulation failure, one of the things that's really important to determine with your patient is, are they taking their medication and are they taking it correctly? So with rivaroxaban, we all know that it's a once-a-day medication, so risk of non-compliance is thought to be lower than for BID drugs. However, rivaroxaban is also very specific in terms of it does need food to optimize its absorption. So for patients who are on 15 milligrams or 20 milligram tablets, they need to take their pill with food to optimize absorption, and food does that. It increases absorption by about 40%. And so I have seen failures of rivaroxaban in patients who don't take it with food. But when we ask our patient, she takes it daily, she takes it with her meals. And so the risk of failure here is pretty high because she's taking it appropriately. So next we need to consider, we've determined, yes, it's a failure of rivaroxaban. What are we going to do? What are the best treatment options that are available? And the best options are really dependent on where you're located. So in some community emergency departments, having alternative anticoagulants available and easily accessible for your patients can be a barrier. So my preference in this patient would be to stop her oral anticoagulant and switch her to low molecular weight heparin if that's available to your patient. I know we all have that in the emergency department, but continuing that on an outpatient basis can be challenging if community pharmacies don't have it. And it also depends on whether or not you have close follow-up for your patient with a quick referral system to a specialist, for example. So while that might be the best option to stop rivaroxaban and start a low molecular weight heparin, an alternative option that you could consider is, instead of stopping the rivaroxaban, increasing the dose of rivaroxaban to PE treatment doses. And so this is where there's that difference in treatment dose for VTE compared to AFib dosing. And it's important to know that distinction. So treatment dose of pulmonary embolism and deep vein thrombosis with rivaroxaban is 15 milligrams twice a day for 21 days, followed by 20 milligrams once a day after that. And because she does have chronic renal insufficiency, we also need to keep a close eye on her renal function during this period of higher dosing, because keep in mind, she also had a slight bump in her creatinine at presentation. So this could be an alternative option if you don't have low molecular weight heparins readily available to you in the community. So now that we've managed what we're going to do from an anticoagulation perspective, one of the things to consider is, why did she in fact have that breakthrough thrombosis? And there tends to be an underlying procoagulant state that's driving this. Now, this patient is elderly, she's 74, and because of that, age being her greatest risk factor, the most likely thing that's driving this would be an underlying malignancy that hasn't been diagnosed yet. And so it would be important for her to follow up with her family physician to have age and gender appropriate cancer screening done. And so for her, that would include mammography, as well as GI assessment. So either FIT testing or colonoscopy, if not recently done. Other things to consider, of course, would be pap smears and other investigations based on her risk factors. If all of that were to be negative, then really there aren't many other things that I would do to work up this patient. But what I would consider doing is a workup for acquired thrombophilia, namely antiphospholipid syndrome. And with that, I would suggest a referral to either hematology or thrombosis, or even general internal medicine can help to facilitate that workup. Other thrombophilias, such as the genetic thrombophilias, would not be relevant given the patient's age, and so I wouldn't do any of that. But really the one that would be most important if the malignancy screening is negative would be to ensure that she hasn't acquired antiphospholipid syndrome. And I'm going to move on to my next case, actually, and we'll do questions at the end. So the third case that I have is a different patient. So this is a younger woman. Her name is Pauline, and she's 28 years old. And she does have prior history of deep vein thrombosis that was related to oral contraceptive pill use. And this is actually a woman that I saw a couple of months ago in the summertime in my thrombosis clinic after she had presented to the emergency department. And she went to the emergency department with acute onset of left-sided pleuritic chest pain. And so I'll give you a little bit more of her history. As I mentioned, she had an OCP-related DVT and had a short course of anticoagulation for 3 months. She came off her hormone therapy and has done well since that time. What caused her to present to the eMERGE was when she was attending a work Zoom meeting, she developed sudden onset of left-sided pleuritic chest pain. And it was present during the meeting, and then it persisted into the next day. And so that's what prompted her to seek medical attention. Other than this, she's been very healthy. She doesn't take any prescription medications, and she does take an over-the-counter multivitamin. She had been told never to take any hormone-related therapies again without consulting a physician. So she hasn't been on any OCP or other hormone-related medications. In the emergency department, she looks quite well. Her vitals are listed here, and you can see that she's not tachycardic or hypertensive, normal saturations, and again, very normal physical exam with no findings of lower extremity edema or pain on palpation of the deep venous system, and her chest and cardiac exams are normal. Again, her lab investigations preliminarily done are again normal. She's not anemic, normal renal function. Troponin is normal, and her ECG shows sinus rhythm. Chest x-rays, again, normal. So I'm going to go to what is next. And of course, given her history of OCP-related DVT, I think it's appropriate that we think about pulmonary embolism and do we need to investigate for that. And so again, we're going to go to Poll Everywhere and consider what is our next step when deciding on investigations for pulmonary embolism. So I'll ask you guys to please vote, and I'll wait a moment while you're doing that. Okay. Okay. good. So I think with our options here, so these are the same options that we saw in the other two cases. And looking at D-dimer is certainly important. Determining what her pretest probability is also important. Keeping in mind that, of course, the Wells score does factor in prior history of VTE. And so it is an objective marker that's included in the Wells criteria. And we're sort of evenly split between some of these. Now, depending on how you want to interpret this and how you want to pursue this, I do think it is important that we determine what her pretest probability is. And so I think C is very appropriate. With deciding on what her pretest probability is, that prompts you to either order a D-dimer or not. And again, if you're using the Wells score to decide that, then if she has a score of 4 or less, you would order a D-dimer to tell you whether or not imaging is required. If you were to order the D-dimer alone, if you're using the years algorithm, then again, we'll see on the next couple of slides what our cutoff is. So again, I've borrowed this slide from Dr. DeWitt, and if the pretest probability is 4 points or less, then we're going to use the manufacturer's cutoff because our patient is younger than 50 years, so we're using, or 50 years old, so we're using 500 as our standard cutoff for D-dimer. As I mentioned, she does have history of deep vein thrombosis, but she doesn't have any of these other relatively objective findings. One of the subjective things that we as physicians can incorporate into the Wells score is whether or not we think pulmonary embolism is the most likely diagnosis in this patient. And if you do feel that PE is the most likely diagnosis, again, you add 3 points, giving her a score of 4.5. So if you have a score of 4.5 or higher, then you would pursue imaging and you wouldn't need to order a D-dimer. However, given that she is young, she's only 28 years old, I do think it's important to be cognizant of radiation exposure. So this is someone who, because of her history of DVT, whenever she presents with any sort of shortness of breath or pulmonary embolism type symptoms, whether it's chest pain, pleuritic chest pain, shortness of breath, PE is always going to be a consideration. So I think it's important that we be judicious about jumping right to imaging. And I think it's important to consider what the pretest probability is and adding in that D-dimer to help you make that decision. So as I mentioned, because she's younger than 50 years, we can't use an age-adjusted cutoff, but we could consider the higher threshold for the years algorithm if she didn't have any of these points for the years algorithm. If you feel that PE is the most likely diagnosis, then you use the standard cutoff of 500. She doesn't have hemoptysis and she didn't have any clinical findings of DVT, and so we wouldn't factor those into that score. So nonetheless, we do a D-dimer and it is slightly elevated. It's 528. Now you're saying to yourself, my gosh, do I really need to do a CT scan? It's only 528. I thought it would be so much higher if she really had PE. The fact that it is abnormal, the fact that she does have pleuritic chest pain with that background of deep vein thrombosis, I do think that, you know, with those factors in place, you could consider ordering imaging, and CT scan would be the thing that gives you the most definitive answer. And if you don't have an alternative diagnosis, her score on the Wells model does become 4.5 and you would pursue imaging. And so a CT scan is done and it's negative. And this is a really important and helpful thing. What the CT scan also shows you is perhaps an alternative diagnosis. So she had mucus plugging seen in the airways, suggesting small airways disease. And she was treated with bronchodilators and her symptoms improved. She saw me in follow-up and followed up with her family physician as well. So all of that to say that the pretest probability is helpful in deciding whether or not you need to order a D-dimer, and that D-dimer does help you to decide on next steps regarding imaging. And I will stop there, and perhaps Dr. DeWitt can join us and we'll take some questions.
Yes, so wonderful. Thank you very much, Dr. Castellucci. We have a lot of questions, so I'm going to try and do them kind of rapid fire, and either of you chime in. I'll start with the emailed ones. Is the level of D-dimer proportional to the amount of clot burden? Does a D-dimer of 5,000 represent a clot 10 times higher than a D-dimer of 500?
Yeah, I can answer that to a degree. There have been a couple of studies showing that the higher your D-dimer is, the more likely you are to have pulmonary embolism, and also the worse your outcome and potentially the larger the burden of clot. However, we all know there are other things that can cause a high D-dimer. So it doesn't really help you when it comes to testing, because you still don't know how likely the patient is.
Okay, rolling on. If a patient presents, sorry, I'll just do the rapid fire. Presents short of breath more than 2 weeks, is the D-dimer still useful? Some authors say more than 3 days makes it useless.
If it's okay, I'll add to that again too. So, pulmonary embolism isn't just a one shot in the dark. It's not something that's there one day and gone the next. It's a systemic disease. So if patient has pulmonary embolism, they have ongoing clotting. Their clotting system remains active for weeks at a time. So even though they might have had the embolus yesterday or today or a week ago, they still have ongoing clotting. DVT is going to be getting bigger. There could be more clot forming in the lungs. So yes, you can use D-dimer even if they've had symptoms for weeks.
Excellent. Just sliding up here. Does warfarin or any of the DOACs affect D-dimer level?
I can answer that, Kirsten. So that's a really important question because yes, anticoagulation does impact the D-dimer. And in fact, we don't really know how to interpret a negative D-dimer in someone who is on therapeutic anticoagulation. So for example, in the second case that I presented, if that woman had a normal D-dimer or a negative D-dimer, in fact, if you had a clinical suspicion of pulmonary embolism, then I don't think the negative D-dimer is in and of itself is enough to say that you don't need to investigate. So yes, being on therapeutic anticoagulation can give you a falsely negative D-dimer. And so I think that's an important thing to consider when you're working up for PE.
Okay, I'm going to combine these two questions with reference to the 1 in 20 false positives. Do those represent mainly subsegmental PEs where there might be a choice to treat or not to treat? And secondly, how do they know that they're false positives?
Yeah, it's a great question, and it's almost impossible as a thrombosis physician to decipher that unless you have the D-dimer and the clinical probability documented in the chart. So it is virtually impossible to say when they come to clinic that this is not really pulmonary embolism. And there have been literally just a handful of studies looking at the false positive rate. We used to think that subsegmental PE was not an issue. It is an issue. We know that a number of these cases actually go on to develop ongoing VTE and may have pulmonary embolism if you look in the lungs, or develop a more sizable deep vein thrombosis when you look in the legs that week or a week later. So yes, the false positives are more likely to happen in the very small vessels, the subsegmental vessels, but not all subsegmental pulmonary emboli are false positives.
Okay.
It probably doesn't help, but yeah.
I think we covered PROC. What tool do you use in pregnancy?
Great question. I would use YEARS. YEARS is the most validated testing strategy for pregnant patients over all strategies. So I would use, it is a slightly pregnancy adjusted strategy. So they say, if you have signs of a DVT in the leg, do the ultrasound first in that leg. But if there's no signs of DVT, you don't do an ultrasound.
And another really great question, quick one from Monica, about the specificity. Given that there are other diagnoses in your differential, is ordering a D-dimer on everyone a good thing? So, I mean, could we actually paradoxically increase imaging use by having a lower threshold to order D-dimers, considering that the D-dimer is going to be positive 50% of the time in negative patients?
No, the way I think of it is, am I testing for pulmonary embolism? Is this a patient that I would get a CT scan on? If this is the patient I would do a CT scan on, then I'm going to do the wells first, and I'll do a D-dimer if that's appropriate. So you don't do a D-dimer to see if you need to test for PE. You do a D-dimer because you've already decided to test for PE, and the only thing it can do is reduce the number of CTs that you're going to order.
Excellent. Bioavailability difference without food, is that standard for all DOACs or just rivaroxaban?
Rivaroxaban specifically.
Okay. Are there concerns of using low molecular weight heparin with renal impairment?
Yes, absolutely there is. So if creatinine clearance is less than 30, therapeutic doses of low molecular weight heparin should be avoided, and IV unfractionated heparin would be used in its place, so admission to hospital.
Okay. If anticoagulants make interpretation of a negative dimer suspect, should we not bother with D-dimers in this population?
That's a good question.
Go ahead.
You know, if you ask 3 different experts, you get 3 different answers. In my practice, I do D-dimers and I use the D-dimer because my thinking is that if they have clot, then it's still going to be raised. So we know that months out after a clot, D-dimer might be suppressed and lower on anticoagulation, and when you stop, it might rise. But we don't know that if you have sizable clot, that suppression is enough to cause you to have a low D-dimer, because D-dimer is a direct measurement of the amount of clotting that's going on in your body. So that's the way I look at it. I use it.
And in trauma, would you bother doing a D-dimer in someone who had trauma a few days previously?
Yeah, I would always do a D-dimer, always. I would never, there's no utility in guessing the D-dimer, you know. If you're going to play the guess the D-dimer game, then you're never going to order it. So I would, for cancer patients, for everyone, I do a well score, and if it's 4 points or less, I do the D-dimer.
This is really hard to do in a rapid fire. COVID and PE risk. What's the one thing emerged physicians need to know about it? That's a trick question.
Absolutely. So I think we've all heard that there is that pulmonary embolism risk. In the early days of the pandemic, ICU patients had been identified to have about a 20% incidence of pulmonary embolism when they looked for it. Patients admitted to the hospital ward, about 5%. So it's certainly there. If you do have clinical suspicion for it in addition to COVID pneumonia, I think it's important to again determine your pretest probability. Of course, none of this has been specifically evaluated in COVID patients, but I do think it's still a place to start determining your pretest probability and doing a D-dimer. We know that those markers are also elevated from COVID, but it could still be useful. I have seen relatively normal D-dimer levels at the start of COVID infection, so it is still helpful.
Last question I think we have time for. Do you support that a well score of 0 effectively rules out a PE, or would you always do a D-dimer in this case?
Yeah, well score of 0 categorically does not rule out pulmonary embolism. And in fact, most of the cases of pulmonary embolism that you diagnose in the emergency department have a low probability, because 85% of the patients we test are low probability. So just the pure fact that all of the people we're testing are unlikely, we will find more blood clots in people who are unlikely than likely. So a well score of 0 is absolutely not designed, not aimed, and not safe to rule out pulmonary embolism.
Fantastic. And I guess that's where you bring your perk in if you want to try and avoid doing a D-dimer. So just in the interest of time, respecting people's evenings, I'd like to thank both Dr. DeWitt and Dr. Colucci for absolutely incredible talk. I mean, I saw the slides beforehand and I learned more listening to the talk as well. This session has been accredited by the College of Family Physicians of Canada and the Royal College of Physicians of Canada. Please don't forget to complete your evaluation forms and claim your credits, and you'll get a certificate of attendance mailed out by CAPE together with the evaluation link. Please keep an eye open for other upcoming CAPE live and on-demand educational webinars, and please join us again. And if they're as good as these 2 speakers have been, I think it's going to be worth your while. Thanks again to Drs. DeWitt and Castellucci for wonderful talks.
Thank you.
Thanks, everyone.